long story short, you're not going to have to do this much longer where you have to get up early to be at clinicals, to wait, or to be in clinicals with Desmond, wait around all day, and then show up over here at 2. This is the only class, this is the only time you have to do that, where you're in clinicals and expected to be in a class on the same day. This is the one and only time. So we're definitely on the tail end of you guys having to do that, because I know it's an exhausting day for you.
I ain't gonna lie, the first week was like horrible when it came to like.
Sure.
That's classes we had none studied.
Right. Right. Now
4
what we're
hours.
gonna do, right. So again, only time you're gonna have to worry about that. But regarding content, we talked last week, what was it about, the neurologic exam. This is, I wish I could say it gets more exciting. This is on lab stuff. And so there's a reason I got into the field I did, because sitting around analyzing laboratory stuff was just not interesting to me. But that being said, the lab stuff, the tests, the things that are analyzed and done ultimately will be important for us to understand and know. Now let me go ahead and say this. I've gone through the chapter, I put things together in today's presentation, today's PowerPoint. This is the only information you will be responsible for knowing, okay? If there's something that you see in the textbook that I didn't even mention today or even go over that particular lab or information, it's because I'm not going to ask it. Not that it's not important, but for us right now to know and understand that, we're not ready for that yet. In addition, with every single test or every single value, something that's measured, there's going to be normals, right? There's going to be numbers associated with it. Not every single thing am I going to expect you to know the numbers with. If I give you a number on the slide, it's because I want you to know it. And if I give you a number on the slide and I put it in bold, wink, wink, hint, hint, that means it's really important. John wants to make sure I definitely remember that, because he's going to ask it. But if there's things, and as we go through, you'll find there's things, he doesn't mention a high and low number. He may say, I need to know what it means if it's elevated or decreased. So elevation or decrease, yeah, there's things you need to know about that. But as far as knowing the specific normal number, because trust me, if we did all of that today, we would need to test on it before you would forget about it, because there's a lot of numbers, there's lots of values. So lab tests, diagnostic tests are a huge part of medicine. We actually do some diagnostic tests when we do the ABG. Now that is not going to be discussed here. That's in another class on another day. But they can be used to diagnose, treat, monitor a patient's health status. And of course, our respiratory patients do undergo many different diagnostic tests. We need to understand what those tests can mean or what they indicate. Now, like I said, there are going to be some normals that you're going to have to know. Normals can vary based on who the patient is. Age is one example. If you take an adult patient's value versus a neonate's value of whatever topic, those things could be different. Those values could be different. Let's get in and talk about some of the most common blood tests. Okay, so some of the most common blood tests you need to know. So let's talk about what blood is composed of. We did mention this the other day in one of the other classes, but plasma, large portion of our whole blood is plasma, about 55% of it. Plasma and other soluble substances like electrolytes and hormones and lipids and those sort of things are floating around in our blood plasma. But the other portion are cells. Now a small portion, small amount, being the platelets, white blood cells. The other, obviously in red, to indicate the red blood cells. Terms here, platelets, also known as thrombocytes. White blood cells, also known as leukocytes. Red blood cells, also known as erythrocytes. Now, I could use those words in a question asking about the erythrocytes. That's another way of asking about the red blood cells. Or leukocytes, asking about the white blood cells. So just be careful with the terminology. Sometimes folks say, John, why don't you just say an increase in the white blood cell count? Why are you using the term leukocytosis? because that's the word the NBRC is probably going to throw at you, and you need to understand what the word means. And we'll go over all these things as we go through. All right, so CBC, probably one of the most common blood tests performed, complete blood count, looking at white blood cells, red blood cells, and platelets, looking at not only their numbers, looking at their size, looking at their shapes and appearance. All that can be part of the complete blood count, the CBC. White blood cells, we should already know this, part of our immune system. When we're exposed to invading pathogens and microorganisms, hopefully our white blood cells go and attack that invading pathogen. White blood cells are developed or formed in the bone marrow or lymphoid tissue. From there, they will then enter our bloodstream to again go and attack the invading pathogens or microorganisms. So white blood cells are a very generic word for all of the different types of white blood cells that we have in our body. From neutrophils, eosinophils, lymphocytes, basophils, monocytes, among others. Okay, but these are the primary ones. Neutrophils are the most abundant of the white blood cells. So 50 to 70% of our white blood cells are neutrophils. Again, mentioned they're produced and stored in the bone marrow before they're released into the bloodstream. It does take 10 to 12 days approximately for the neutrophil to form. Once it's released, it has a very short half-life of about 6 to 8 hours before that neutrophil is no longer going to be capable of doing its job. And hopefully, if we're healthy, hopefully there's others behind it that can go ahead and replace and continue the battle or continue the attack over the invading microorganisms. I will say this is considered our first line of defense against invading pathogens or microorganisms, the neutrophils. Again, remember, they are the most abundant of all the white blood cells, are the neutrophils. Eosinophils, a very small component of the white blood cell, anywhere from 1 to 3%. Basophils, even smaller, 0 to up to 1%. All right, now what are they responsible for? Again, white blood cells generically attacking and invading pathogens or microorganisms. Both of them involved in the immune system regulation. They help to control parasitic infections, or maybe the neutrophils are attacking more, oh shoot, the name went right out of my head. Bacterial infection, sorry, had a moment. Small TIA, it's okay, it'll stop in a minute. That's a joke, by the way. TIA, mini stroke. Bacterial type infections for the neutrophils, this more parasitic infection plus reaction to allergens. We'll see it again in just a minute, but some of our asthma patients, their asthmatic reaction is more of an allergic reaction to something in the environment. If we look at their blood count, we may see an elevation in their eosinophils. And I know specifically it's because of an allergic reaction, not necessarily an invading microorganism or bacteria or even virus for that matter. Lymphocytes, that's the second most abundant white blood cell, and making up anywhere from 20 to 45% of circulating white blood cells in the adults. Again, still attacking those foreign microorganisms and pathogens. A few of the major types of lymphocytes, T cells, B cells, and my personal favorite, natural killer cells. Somebody that was coming up with these names way back when was getting creative. I like that name better than B cell and T cell. Regarding viruses, it's more of these, the T cell in particular, that's going to help to attack those viruses. For example, a patient with HIV, a virus, we notice their T cell count tends to be very low, indicating the deficiency that they have there in fighting infection. Monocytes, anywhere from 2 to 11% of the white blood cells, their function is phagocytosis, engulfing the invading pathogens. We know in our lung, the macrophages are a type of monocyte. Again, we know the macrophages in the lung don't necessarily kill the invading microorganisms. They clean up the mess. They engulf, phagocytize the invading pathogens that are there. All right, I think this is really our first true number when it comes to normal values. White blood cell count. Normal white blood cell count being anywhere from 4,000 to 11,000 microliters. Sorry if you don't have this on your PowerPoint. Go ahead and add it. Funny looking little U with an L, standing for microliter. All right, so normal white blood cell count anywhere from about 4,000 to 11,000. Again, this is in the adult. This is in the adult. What's that?
It's on the keyboard, right? It's not on the keyboard, right? Okay.
I'm not sure what
The
you mean by
U.
The keyboard.
The U. It's not in the
Oh,
keyboard.
yeah, sorry, yes. Yeah, it's one of those fancy things, you probably find it under symbols and you have to look. Yeah, sorry. You know where I had to get that, because I couldn't find it on my keyboard either? I copy and pasted it.
Or whatever.
You know, I told you I'm trying to get better with
Handwriting.
reading
Yeah, but
books
mine-
online. Like, well, fine, I'll just take it and I'll put it in my PowerPoint that way. Because I sure as heck couldn't find it either.
Like a
All right,
short,
so
like-
some terms here. So some terms.
There's a like
Leukocytosis, an increase in the white blood cells. And again, I'm not saying any specific one, but just generally an increase in white blood cells. What do you suspect's wrong with someone who has who has leukocytosis? Infection of some sort. You know, an elevation in white blood cell count. Leukopenia is a reduction in the white blood cell count. Who do you think can develop leukopenia? Cancer patients. They may have trouble producing their normal invading defense mechanism. All right, so those terms. Now, notice I'm not associating numbers specifically, but right now, if we can say, well, this is normal, anything above, leukocytosis. Anything below, we'll call it leukopenia. Okay? Elevation versus reduction in the white blood cells. Now, if we get specific, well, certain white blood cells. So, looking specifically at the neutrophils. If we have an increase in the neutrophils, the term neutrophilia would be used. And again, neutrophils are first line of defense against invading pathogens, microorganisms, bacterial infections like a bacterial pneumonia. We would see an increase in the neutrophils, or we would see neutrophilia. A reduction in neutrophils, neutropenia, again, maybe some of the familiarity between some of these words. Again, cancer patients, as we mentioned before, things that could affect the bone marrow, patients undergoing chemotherapy, and still cancer patients undergoing chemotherapy or radiation therapy can impact their ability, impact their bone marrow to produce white blood cells. And there's others, there's diseases and conditions, but we're just going to hit some of the highlights. Eosinophils, eosinophilia, an increase in the eosinophils. I said before, we see that eosinophil increases with allergic reactions. Goes back to our asthma patients who have an allergic reaction. That's what sets their asthma off. Maybe it's the season, the allergens, the pollens in the air that set their asthma off. But maybe it could be something different, not necessarily allergy related. Or what about pets? The pet dander, the fur of a cat or a dog, setting an asthma patient off. Again, we would see an elevation in their eosinophils, known as eosinophilia. All right, let's transition away from the white blood cells and talk about the red blood cells. Red blood cells, again, produced in the bone marrow, have a lifespan of 120 days exactly. 120 days. So those red blood cells you have floating around right now that were just produced, you're good for the next 4 months with those same red blood cells. But after 120 days, they will die off and be replaced with new ones. The shape, as we mentioned before, with sickle cell anemia, normally rounded shape, easily slides through the bloodstream, doesn't get caught or hung up unless the patient has some sort of clotting disease or clotting issue. The main component of the red blood cell is the hemoglobin. And I don't need to elaborate too much more about hemoglobin because I think I did the other day spend enough time talking about the importance of hemoglobin and what hemoglobin does for us regarding oxygen. It carries most of the oxygen in our body, correct, hemoglobin? Correct. All right. Hematocrit. Hematocrit. That's a comparison of the amount of red blood cells in comparison to whole blood. Okay, so hematocrit's just what's the percentage of all of this blood that is red blood cell. That would be considered the hematocrit. In this picture, I think it shows kind of 50% of the total blood. I guess that looks like 50%. 50% of the whole blood, that would be the patient's hematocrit level, 50%. Normal, I put numbers in there in bold. Wink, wink, hint, hint. All right, so normal hematocrit for a male is around 45 to 54%. Again, the percent of whole blood that is strictly red blood cells. Ladies around 35 to 49%. Hemoglobin, again, not to preach on that again, but again, the main component that is carrying oxygen in our body, in the bloodstream anyways, is hemoglobin. Know what normal is, and yes, it is a little bit different male versus female. Okay, so make sure the numbers that are on the screen right now, you make sure you jot down, create a flashcard, whatever it takes to remember what they are. All right, anemia, reduction in the amount of hemoglobin or reduction in the amount of red blood cells. Again, without going into it all over again, we know if someone's anemic, that's going to affect their ability for their blood to carry and transport oxygen to the tissues. So we will see patients who, even though their saturation number is good, still could be complaining of shortness of breath and the inability to breathe because they just have very small number of hemoglobin to be able to transport and carry oxygen. Now, our body's normal response to hypoxia, again, if our tissues are not receiving enough oxygen, our body will release a hormone, this is one of my favorite words to say, known as erythropoietin. Erythropoietin. That hormone, when it's released, again, released from the kidneys, will cause our body to increase production of red blood cells, meaning increase production of hemoglobin to be able to transport and carry oxygen. It's why we tend to see those people that start with a C, those three initials, end in a D. C, oh yeah, thank you for saying that. Yeah, those COPD people who are chronically hypoxic. When we look at their CBC and we look at their hemoglobin levels, we notice their levels are much higher than the average person. And why is theirs so high? Because their disease, their illness leads to chronic hypoxemia. Their body produces more red blood cells to produce more hemoglobin so they can carry oxygen, more oxygen for them to get to the tissues because the tissues are being deprived.
What if somebody
They would be struggling. They would be struggling. Not that, and of course, that definitely could happen. Anemia is a quite common problem in our society today. But yeah, you could have patients.
If their body's like not producing it, like is the COPD like going to, because like they have that and the body realizes that there's like less oxygen, the body makes up for by producing more
Red blood cells, more hemoglobin.
So if it doesn't do that, then is that considered anemia, or is it anemia, or is somebody anemic because they
It could be multifactorial.
Oh.
Now, normally with COPD, and I shouldn't say COPD exclusively, it's bad of me to say it, any disease, COPD can be included, of course, cystic fibrosis could be another, any disease that leads to chronic hypoxemia, because of the disease and illness, pulmonary fibrosis could be another one, chronic hypoxemia, and the tissues aren't getting enough oxygen, the kidneys will release erythropoietin so they can produce more red blood cells. Now let's say it's that same patient, they have something else going on with them. They have leukemia, and so now that's affecting the red blood cells and the inability to produce red blood cells and produce hemoglobin. So again, that example you're given, yeah, the patient could have CF, COPD, whatever the case may be, and also develop leukemia, so they're getting their blood productions being hit from two different perspectives. General symptoms of anemia: pallor. Anybody know what pallor means? Their coloration, pale. Again, we all have different skin tones and skin colors, but if we were to be pale, just if we lose our own color, that's what pallor is. You know, you can look at somebody and go, you just don't look right. Your color doesn't look good. You look, pale white or gray or ashen. Those are some other words that are used. Again, that could be a sign of anemia. Others can include fatigue. I think that's not hard to imagine. If your body's not getting enough oxygen, you're going to be extremely fatigued and tired. You can't go from here to there without, needing to sit down and rest. Dyspnea, shortness of breath, of course. We talked about, I think, in another class about iron deficiency being a primary cause of anemia, and that's true. Polycythemia, the exact opposite. Okay, so an increase in the number of red blood cells or increase in the amount of hemoglobin. Again, this could be overstimulation of the body to produce more red blood cells. This could also be our cystic fibrosis patient or pulmonary fibrosis patient with chronic hypoxemia, where the body produces more red blood cells, more hemoglobin, so their counts are higher. That's not unheard of. Or yes, the COPD patient. Patients who are chronically hypoxic, living at high elevation, where the pressure, barometric pressure is a lot lower, the air is lighter, even though it's still carrying 21% oxygen, the air is much lighter, but what's actually oxygen-wise getting to the tissues is much less. So again, natural reaction of the body is to produce more red blood cells to be able to carry more oxygen to the tissues. Some heart diseases, heavy smokers. Again, heavy smokers. What's, aside from all the cancerous stuff that's in cigarette smoke or tobacco smoke, what else are they inhaling? What specific gas? Carbon monoxide, which, again, for the smoker, their hemoglobin would rather carry that carbon monoxide than the 21% oxygen in our atmosphere. And so there's another example. So the body is going to be hypoxic for those heavy smokers. And we could see potential polycythemia with those patients. We said this before earlier this semester. Again, it increases polycythemia. The more red blood cells that are there, it increases the viscosity, the thickness, the sludginess of the blood. And what important organ has to pump all that stuff around? Our heart. And that can put added stress on the heart over time. All right, platelet count. That's dealing with clot formation. So it's the reason if I accidentally nick my arm here or cut myself shaving, I don't bleed all over the place, because I have adequate clotting factors to prevent me from bleeding all over the floor and becoming anemic. Now, of course, there could be situations, certain diseases or illnesses, conditions, where platelet counts can be affected, and maybe the patient will bleed for a lot longer based on the disease or pathology or illness that they have. The term thrombocytopenia. Notice with this, I didn't give you any numbers to have to worry about trying to memorize. But thrombocytopenia is a reduction in the number of platelets. What's going to happen to that patient when they bleed? They're going to keep bleeding.
Bleed out.
They're not going to be able to clot as fast as, say, you or I. So, again, I'll use the leukemia patient as an example. They see definite reductions in their platelet count. So if they cut themselves even accidentally, they could bleed a whole lot longer. They can get nosebleeds that will not stop. Where if it was you or I, sure, I get a nosebleed, but I can get that to stop fairly quickly. I could see things on their skin, lack of a better word, just bruising of the skin that doesn't appear to heal. So some terms here. Petechiae, those are very small, kind of reddish or purplish spots. Purpura, same thing, but the spots tend to be a little bit larger. Ecchymosis, I need to name my next pets some of these names, and people wonder, come here, ecchymosis. Ecchymosis is larger, looks like a bruise, but again, won't heal. that could be an indication that maybe something's going on with someone's platelet count, the ability for them to clot and be able to stop bleeding. For us as respiratory therapists, some of the things that we do, such as drawing an arterial blood gas, we stick a needle into the artery to draw some blood, I remove the needle. Yes, of course, even for you, I'm going to hold pressure for a good long period of time to make sure it stops bleeding. But for someone with a low platelet count, what's going to happen to them? You know, the time I would have to hold pressure for you to get you to stop bleeding is going to be much shorter than it would be for someone with thrombocytopenia or a low platelet count. They may bleed for what feels like forever. You know, just so you know, when we stick a blood gas, we should hold site pressure for a minimum of 5 minutes. Knowing this patient has a low platelet count, I may want to double that at minimum, 10 minutes, because it may take a while before it ever clots. Some of the other stuff that we do, suctioning. Again, suctioning can be very traumatic to the airway. If I'm doing an NT suction or even down an ET tube, if I let that catheter get it outside that ET tube, like deep suctioning that we talked about before, nicks the airway, nicks the trachea, causes some bleeding, they're going to bleed forever. And I noticed as I'm suctioning, boy, a lot of blood here. This was more than it was earlier in the day, maybe because I was too aggressive when I suctioned the patient, for somebody who already had a low platelet count. Blood chemistries, all right, another type of test or grouping of tests here, blood chemistry. Sometimes you hear them referred to as panels, basic metabolic panel. Now, there could be a lot more things than what's listed here that are being measured, but just trying to hit some of the important ones, some of the highlight ones. Electrolytes, extremely important for us to understand and know. We'll talk about glucose levels as well as renal function tests. So let's start with the electrolytes. Trying to keep this very simple, and hopefully you can remember this. Memorize the numbers, but remember this. Sodium, a very important electrolyte. Normal sodium levels anywhere from 130 to 145 milliequivalents per liter. Sodium's regulated by our kidneys. Now, terms here, hypernatremia versus hyponatremia. Which one means the sodium levels are increased? Hyper, as opposed to reduced or decreased, hyponatremia. Potassium, second electrolyte we'll talk about. And again, these orders are in no particular order, but I will say electrolytes are all very important. But if I had to handpick one I'm most concerned with, it would be someone's potassium. Now, normal potassium is around 3.5 to 5 milliequivalents per liter. Again, extremely important. And again, electrolytes are important for muscle function, but when I'm talking about potassium in particular, it has significant, if I have an abnormal potassium level, high or low, significant issues related to the heart. And you may wonder why a patient's having some sort of cardiac arrhythmias, some sort of cardiac condition. It could be from a potassium level that is off, too high or even too low. So hyperkalemia, increase in potassium. Hypokalemia, decrease in potassium. Kalemia, why is that? Because potassium, it's not P, it is K. It is K. All right, a couple of others here. Chloride. Normal chloride levels from 98 to 107 milliequivalents per liter. We could see hypochloremia, reduction with severe vomiting. Hyperchloremia, elevated levels with certain diseases of the kidneys or prolonged diarrhea. Patient's been sitting on the toilet for what seems like hours or days on end. That could affect chloride levels. The last one, total, what is CO2? I'm not sure, I forget that one. I know that one the least. Total carbon dioxide. Now this, just so you know, this is a little bit different number than what we get from our ABG. Okay, still related to carbon dioxide by all means. This is a little bit different than the ABG CO2 that we'll talk about in the future. All right, but it is representative of total carbon dioxide in the bloodstream. Now, CO2 is really not an electrolyte, but it is part of the electrolyte panel that may show up. It is a vital component of acid-base balance, which we will talk about more when we get to arterial blood gases. And we definitely see our COPD patients with retained carbon dioxide levels, elevated CO2 levels. Good. All right, so electrolytes, good representation of muscle and cardiac function, especially potassium as it relates to the heart. Glucose, what is glucose? Sugar, all right? We need glucose, primary carbohydrate in the body that we do need for energy, for metabolism, for normal function. You do need to know what a normal fasting, what does it mean when you fast? No food, nothing's been consumed, probably the night before, and you're having the blood draw this morning to measure glucose levels. Should not be 3 digits. I'll make a shortcut there. Shouldn't be 3 digits. All right? Shouldn't be 3 digits. Nothing over 100. Anything over there, then we worry about maybe some problems with their blood sugar. All right, so normal range anywhere from 70 to 99 milligrams per deciliter. Glucose is regulated by insulin. Our body produces insulin. Now, if I'm a diabetic patient, I may have some issues being able to produce insulin. And that's why a diabetic patient would have to take insulin injections perhaps. Insulin will help regulate and keep those blood sugar levels down. If I'm not producing insulin, what happens with my blood sugar? It could climb sky high. And then it could as easily then turn around and bottom out the other direction. And that's why our poor diabetic patients do have to be very cautious and very careful making sure their glucose or blood sugar levels are where they're supposed to be.
What's the highest glucose you've seen?
Mine yesterday was 430.
Wow.
When I got diagnosed, it was 50.
Yeah, they can be ridiculously
I've had a patient at like
high.
900 before.
How much?
900.
900, yeah.
You had like 1,400, I want to say one time.
Gotcha. Yeah, that's higher than what I've ever seen. I've seen up into the 900s, 1,000, and I'm like, 4 digits? Holy, I'm worried when it gets to 3. Let alone 600 or 500 or 400, whatever the case may be. So yeah, again, I always think about what was it like decades ago when we didn't have the ability to monitor and measure things. How high certain people's blood sugars must have been, and we just didn't know. It could be our own family members or elderly relatives that have since gone, gee, I wonder what that was. For that person way back when, and how were they able to monitor it and measure it, and our diets, we say we're much healthier eaters now when our parents and grandparents with all the fat and the lard stuff, but I tend to think
They didn't have all the
not that I'm
additives.
encouraging the bad diets and all the fatty foods, but I think we think we're doing so much better today, and I'm not sure we really are. But anyways, I'm getting off topic here. Renal panels. All right, renal panels, BUN and creatinine. All right, so the 2 most common tests to assess renal function. And when I say renal function, what am I talking about? The kidneys. The kidneys. So if I have a patient with kidney failure, renal failure, kidney or renal insufficiency, the kidneys they're working, but they're not working the way they're supposed to, I could see elevations in the BUN and creatinine. BUN stands for blood, urea, and nitrogen, right? So urea and nitrogen are remaining behind in the bloodstream. Urea in the bloodstream? Don't we normally get rid of that stuff? If my kidneys are working the way they're supposed to, and I have to run to the restroom and go get rid of my urea, sure. That when the kidneys are working the way they're supposed to. But if my kidneys are not, and I'm retaining all that waste in my body, no wonder those patients with renal failure, kidney failure get so sick. Or if their kidneys are not functioning properly, why they have to go get hooked up to a machine, they call that dialysis, and this big giant dialysis machine takes the patient's blood out of them filters it the way a kidney would and return that blood back to the patient. And we'll see patients, it's not our forte, it's not our area, but we'll see plenty of respiratory patients that have to go have dialysis. Sometimes we make the trip with the patient to dialysis because maybe they're actually on a ventilator and I have to go with that patient. Or maybe it's my ventilator patient in the ICU and dialysis comes up to them, just depending on the situation and the scenario. All right, so these two specific renal function or kidney function tests. All right, lipids. There's a whole lot of different lipids and fats and cholesterols and triglycerides that we could look at, but I'm really focusing right now for us on two. The HDLs and the LDLs. One of them's the good cholesterol, one of them's the bad cholesterol. So HDL, the high density lipoproteins, that's the good cholesterol. They help to remove the excessive cholesterol from our bloodstream. We want to have high HDLs. And I hope we have low LDLs. LDLs are the bad cholesterol, the one that can cause the plaque buildup in our bloodstream. Atherosclerosis. All right, cardiac biomarkers. All right, there can be some blood tests looking at very specific components of the blood. Those things, along with patient presentation, signs and symptoms, of course, they could do some blood work looking at specific cardiac biomarkers to see, does the blood show that the patient may have myocardial ischemia? Myocardial means what?
Muscle of the heart.
Heart muscle. Ischemia, lack of oxygen, so lack of blood flow, lack of being able to carry oxygen to the heart. So ischemic myocardial damage, or simply stress of the myocardium, of the heart muscle itself. So the ones that you need to know, okay, the first four here, the creatine kinase, or CK, or CKMB, MB is myoglobin, or troponin. And you may see all of these given, all of these measured in someone's cardiac biomarkers or cardiac enzymes. When they are elevated, they're indications of myocardial ischemia, meaning the heart was lacking blood flow, lacking oxygen getting to the heart muscle. Now, when you think about an example of, well, how could that happen to somebody? What about a heart attack? An MI, myocardial infarction, where the heart muscle wasn't able to receive enough oxygen and nutrients. And so the heart's going through major stress, major inability to receive that oxygen and be able to keep the myocardium functioning properly. Again, we can see that from those particular cardiac biomarkers. This was from the textbook that shows even hours or days after someone has an MI, you can still have elevations in some of these values. Now, some of these values can go up very quickly after a myocardial infarction. And again, remember, we're not just looking at the test alone. The patient did present with certain signs and symptoms. Chest pain, shortness of breath, changes in EKG, of course. This just may be one of those additional things that they're doing just to make sure, yep, this is what it was. It is the heart that was suffering, that was going through damage. This other one, the B-type natriuretic peptide, BNP for short, is a very specific test looking for stress on the heart. Stress that would be seen for a patient in congestive heart failure. So when I ask the question, which of the following would be best to assess for a patient with congestive heart failure versus, that's BNP, versus someone with an MI, maybe troponin or CKMB, make sure you can differentiate, because they're not necessarily all going to show the same. CHF, we're looking at the BNP. Myocardial ischemia, maybe post-MI, then we're looking at some of these others. Like I said, troponin, CKMB, among the others. All right, culture and sensitivity. So when you wonder what happens when you take that sputum specimen from a patient, we use that specimen trap as we were suctioning and we get all that nastiness, and we close it up in that Lucan's trap or specimen trap, and I say, I'm glad we don't have that job, because somebody's gonna have to open this thing up, pull out that nastiness, and put it in a microscope and start looking at things. This is the point that they're receiving that nastiness from us. So a culture and sensitivity. The first one, culture. They need to culture and grow whatever it is there. Whatever nastiness, whatever infection is there. They need to grow it. Now, it doesn't happen overnight. It takes some time for whatever the microorganism is to grow. And so, anybody take a microbiology class in college? You probably did some of that, some of the things that, I don't know if they still do it, but I remember we used to do it. We go around and swab like doorknobs and things, public things, and then we grow it and then get totally disgusted and now have to do other things because now I'm worried about what I'm touching and everything that's in there. So when we culture something, it is going to take time for that something to grow. Could take a day or two, 24 to 48 hours, but other things could take weeks, 6 weeks. If it's a fungus or a mycobacterium. One of the respiratory diseases that we'll be discussing later, that's a mycobacterium. Anybody know? I think you said it. Tuberculosis. Tuberculosis is a mycobacterium. So when you suspect someone has TB and you analyze their sputum, well, to grow that mycobacterium, it's going to take how long? 6 weeks. Meanwhile, the patient's, I can't breathe, I'm coughing up blood, I got night sweats, all this other stuff. You know, well, we can't diagnose you until after 6 weeks. We've got to grow it first.
Is
Now,
that with speeding up? Because I know that they can...
Yes, of course. This is just one example. There's other quicker tests, and we would use those quicker tests for something like that. But, you know, standard culture is going to take up to 6 weeks. So, first we got a culture. And I don't know if you can see the slide very well, but kind of this off-color, tannish looking thing, that's the culture. That's the culture of whatever invading pathogen that was growing. So that's what's here, kind of the brownish tan color. Now what we're seeing here is not only just a culture, but it's also the sensitivity. So different mediums are placed inside that culture to see which medium the item that's cultured reacts to or gets destroyed by. So if this is whatever pathogen and these represent the different antibiotics that could be given, are we going to recommend giving that particular antibiotic? Look, it doesn't do a damn thing to this growing pathogen. Something like this, yep, that kills it. That kills it. This one didn't do anything. That one kills it. That one kind of kills it too. Should we give those other antibiotics? But what about this Mac Daddy antibiotic that really kills it, right? That's the one that should be given, right? Because it is definitely, the pathogen is definitely sensitive to this particular antibiotic. Sure.
I've seen this artist who uses cultures and stuff to, I don't know, it like grows all these like crazy stuff and she puts it on these like forms and it's like really cool art.
Yeah,
It's like kind of creepy, but it's
creepy and cool all at the same time. I agree. I agree.
Cool.
Yeah. Let's see how it reacts. Let's see how it grows or doesn't grow. Yeah, that's kind of neat. But that's a culture and sensitivity. So when you hear about something being sent for a C and S, CNS, the C, culture, and S, the S part, sensitivity. So a CNS, culture. Now for us, I always think about the mucus, the sputum that we get. They can do CNS's culture and sensitivity on other things too, but again, I can't help it. It's what we do. Think about the mucus. All right, speaking of mucus, we can also do what's known as a bronchial alveolar lavage, or BAL for short. This is done during a bronchoscopy procedure, where during the bronchoscopy, again, who controls the bronchoscope? The physician, but who's assisting the physician during the bronchoscopy? The RT. So we're the ones that are going to inject the saline inside of the bronchoscope, that the physician will turn around and suction that stuff out, not only the saline, but also the stuff the cells that are near this, and we get what we'll call a washing, a lavaging of that inner airway. And they can do it at multiple locations. And then send that specimen onto the lab to see what is now growing, and can do a culture and sensitivity with that.
Is that kind of like the same thing with like COVID tests, whenever you like swab your nose and then you stick it inside that fluid?
Except look where we are. It
Yeah.
is similar, yes.
It's like the same like kind of thing, like you're wanting to like wash and like mix it all, so you have like this fluid that you can.
Yes, but notice where we are. We're deep in the lung. You know, when we're questioning whether this is a pneumonia or what type of pneumonia, when we have patients, and I don't think I put it on here, but when we have patients who are on the ventilator and we worry about the VAP, anybody remember what VAP stood for? Ventilator associated or ventilator acquired pneumonia, and we want to see, well, what type of pneumonia is it? We can do a BAL. We could do these at the bedside even of our intubated mechanically ventilated patient. So again, it could look at more than just pneumonia, but for now, let's remember this is a way to help diagnose the type of pneumonia the patient has. Yes, I can say patient has an elevated temperature, elevated white blood cell count, elevated neutrophils. Sure, it sounds like infection to me, but we can do this to see specific. And the X-ray has a spot where it looks kind of funny and hazy. That looks like a pneumonia on X-ray. This is a test we can do to see exactly what that pathogen is, what type of pneumonia this patient may have.
I'm not worried about putting water into the lung.
It's not water.
Well, okay, it's sterile fluid.
It's saline.
Okay, well, but are we not worried of putting a
Apparently not.
liquid into the
Apparently not. No, I'm being funny all at the same time. You know, when we talk about when we suction a patient, how we shouldn't really use saline. I may use a little bit of saline just to help kind of lavage the secretions to help make it easier for me to get out. But I'm stressing, we don't like to use saline if we don't have to. And I'm talking about a little saline vial or bullet that has anywhere from 3 to 5 mLs of saline. Really, that's not much. When you go through this procedure, you will, and again, you're assisting the physician's controlling the bronchoscope, you're filling up a syringe with 20 mLs of saline, handing that to the physician puts all of that down there, suctions it out, asks for another, asks for another, asks for another. You could put over 100 mLs of saline.
I got to witness this on a shadow day.
Okay, cool.
and I
How
was
how
like-
many syringes full of saline do you remember?
He went through like 9.
Right, and again, and I'm saying, and again, I'm the one who's saying it, and I'm saying, careful about saline, don't use it. If you use it, just use a little bit. But with the
I thought he was like,
more,
I was,
right,
well no, even just with the bronchoscope, like,
yeah,
I was like,
yeah.
you know, not delicate at all.
No, but we're not technically, because we can see, as opposed to us with the suction catheter, again, I can't see what's on the end of the suction catheter, but I can see what's coming out of the bronchoscope. So we can see the areas that we're lavaging, and we can pull and remove everything. You know, with me, with saline, I squirt a little bit of saline, it goes down the ET tube, ends up in the trach, goes down the right, I can't get back all of that I just put down. But with the bronchoscope, we're pretty deep in the lung with the scope. So we do get most of that saline back out. But it is something to be mindful of, to understand. But it's funny, I had a conversation with the second year students just a couple weeks ago about this very thing. And knowing many of them at this point have got to see this procedure, and I said, by the way, how many have seen a BAL? You know, majority of the class raised their hand. And how much saline was there that you saw? They probably asked you, hey, draw up some saline. And they don't mean just one vial of saline, multiple, so you're not having to keep drawing it up during the procedure. So you have all these vials of saline. But something to be mindful about too, we may also drop lidocaine as a numbing agent. Make sure you don't get them mixed, because there's still a clear fluid, right? Here's all my saline, here's my lidocaine. Jeremy, can you take over for me? Sure. Oh, well, which is which? One of them's going to numb, one of them's going to be part of the lavaging process. Exactly, ruh-roh. All All right, histology and cytology. So could be done through a bronchoscope. In addition to putting saline through a bronchoscope, you can actually go in and remove tissues. You can get tissue samples of the inner wall of the bronchi, for example. So, or simply, through thoracostomy, opening up the patient and getting samples where we're trying to get information about the patient. So, biopsy specimens can be sent to the lab to see maybe what's growing, maybe is this cancer, is this metastatic cancer, is this a benign tumor, something along those lines. Cytology is looking at the fluids and secretions. Again, same thing to see, what is there, what may be growing, and again, for cancer purposes, for lung cancer, that may be something that we're looking at as well. Questions? Was that my last slide?
Yeah.
I have to remind you guys, help me out, remember when I'm at the end. All right, questions? How long was that? Just under an hour.
That's a record.
That is a record. I promise I didn't have any caffeine. This is water. I didn't have any energy drinks or nothing like that. All right. Not that I care. No. So, let me go ahead and go through my questions, and then you guys hit me with any questions you guys have. All right. So, first question: patient's white blood cell count is measured at 16,000. That's microliters. What would this be called? Anemia, polycythemia, leukocytosis, leukopenia, or thrombocytopenia? C, leukocytosis. Leukocytosis. So remember, even though I might not be asking numbers here, I am asking a number here because what's a normal range? 4,000 to about 11,000. So this is definitely elevated. And then what's the word for an elevation in white blood cell count? Leukocytosis. What if I gave you the same question and replaced 16,000 with 1,000? What would be the answer? Leukopenia. Again, an easy way to try to at least start separating answer options. What are the white blood cells called? Leukocytes. So right away, kind of prefix-wise, leuko. Okay, I'm looking for something with leuko in it, and it's either leukopenia or leukocytosis. Any questions on this one? Everybody okay with the picture? Or the question? You jotted it down? All right, next question. Which of the following is considered a normal potassium level? 70 to 90, 98 to 107, 135 to 145, 3.5 to 5. Now, every one of these ranges was from the lecture, was from the PowerPoint, meaning that's a normal for something, but which one is potassium? D, 3.5 to 5. What fruit is high in potassium? Banana. When you go to the grocery store and you go find your bananas, how many are in that little bundle that you grabbed?
3, 4, 5, 6.
That's my way to remember it. Now I know I don't grab 3.5. I don't grab a half banana. I don't grab a half banana, but I'm not grabbing 107 bananas. Now that could be wrong unless you have a big family. Big family, you may need more than that. Just on average. Just on average. You get too many bananas, they're going to go bad and be all nasty unless you like those nasty, gooey bananas. I don't.
You don't buy a crate at a time?
No. I love them. I eat bananas all day long, but I can't go through that many.
You sure wore a banana today.
There you go. There you go. All right, next question. Which of the following levels would indicate polycythemia? So, think back. What does polycythemia mean? And the answer options are a hemoglobin of 19, a white blood cell count of 15,000, sodium of 149, potassium of 5, hemoglobin of 7, white blood cell count of 3,500. Polycythemia? A. A is correct. A is correct. Okay. Elevation in hemoglobin or red blood cell count. All right, any questions on that? That was the last one. Oh, how about that? How about that? All right, any questions for me? Or I'll let you guys run. Hopefully that wasn't too painful today. Just remember, any